It's important to distinguish between the two, and it's equally as important to understand that a comprehensive history and physical exam is important. They mimic each other not only because of location, but the pain referral pattern. So as an example, the back of the neck, or what's called the cervical axial spine, has regions in the back called facet joints. And these facet joints in the back can refer pain along a certain distribution. And typically that is at the level of the occiput, along the neck, and the back of the shoulders. Pain that is originating in the neck, if it's caused by disc pathology or arthritis again, can compromise a cervical nerve, and that nerve can radiate pain all the way down the arm, affecting the hand. Likewise, a shoulder injury may also cause pain referral patterns, sometimes down the side of the shoulder. It is a collection of nerves and vessels that may originate higher up along the area of the neck and go down and pass through the shoulder. It can lead to symptoms of numbness and tingling down the arm and into the hand, and this condition is commonly referred to as thoracic outlet syndrome. That could be either as a result of a vessel problem, where there is compression of the vessel, whether that be an artery or a vein, or compression of the nerves themselves as they course through what's called the thoracic outlet. Looking at the features of where the location of the thoracic bundle would be, if I actually look at the sides of the neck here, there are a couple of muscles here called the scalene muscles, anterior and middle scalene, and at this interscalene area is a common area of compression. Along this area, there can be compression in what's called the interscalene triangle. Additionally, further down, there can be compression between the clavicle and the first rib. And finally, a third area of entrapment occurs distally in front of the shoulder here by what's called the coracoid process and the pectoralis minor muscle. Yet another area of entrapment which may lead to those symptoms of what's called thoracic outlet syndrome. So the first part of physical examination is always to look, and that's what we call inspection. And so right now what I'm looking for is for any obvious bony deformities, any swelling, any erythema. I'm looking for any masses or asymmetry in terms of the muscles of the neck, the shoulders, and then also the back of the neck. I want to ensure that I check for atrophy or any muscle wasting, because that could be a signal as to problems that are originating more proximally. So after I look and I inspect and look at the posture and the mechanics and how the neck actually looks in position, I then check for range of motion. And so I'm going to have Melanie go ahead and look up towards the ceiling and look down towards the floor, okay, and look towards your left. Look towards your right. Good. Come back to neutral position, and I'd like you to bend your head sideways to one side and then to the other. Any pain with any of those movements? Okay. After we've looked at range of motion, we of course do our neurological testing, which includes muscle strength testing, testing for sensation, and assessing reflexes. Afterward, we want to look at special tests. In the case of the cervical spine, we're looking at any evidence of cervical radiculitis or radiculopathy. And so one way to do this is through what's called the Sperling's maneuver. And so what I'll do is I'll have Melanie rotate your head towards the right, tilt it back slightly, okay? And then I'm going to compress over here. And then I'm going to ask Melanie, do you feel any pain going down your arm at all? Okay. If she had said pain, then it suggests that she may have pain along a certain dermatomal distribution. If it was higher up in the neck, it could be at the level of C6, and so C6 radicular type pain would occur along the arm into the thumb. C7 radicular pain would manifest as pain to the index finger. C8 radicular pain would extend to the pinky finger of the extremity. In the drop arm examination, this is an examination where I will actively lift the patient's arm up, and then I'm going to remove my hold on her arm, and I will ask her to slowly bring her arm down along her side. Okay. That was normal. In the case, if this was an abnormality, what would happen is the patient would not be able to gently bring her arm back down to her side. It would simply drop. And if it were to drop, that would be an indication of a rotator cuff tear, specifically an injury to the supraspinatus muscle. In this examination, what one would do is ask the patient to place her arms and extend them outward, flex them outward in the plane of her scapula with her thumbs pointing down. I would then resist her movement as she's trying to maintain that position. If there were pain along the shoulder, that would be an indication of damage or injury to the supraspinatus muscle. Essentially what I would have Melanie do is flex her shoulder to about 90 degrees, adduct her shoulder and bring it across. And if there were pain when I was pressing along this area, if it was anterior shoulder pain, that would suggest pain at the acromioclavicular joint. If there were pain behind her shoulder, that would suggest tightness and or injury to the infraspinatus, teres minor, and or tightness of the posterior shoulder capsule. And in this test, I will palpate along the bicipital tendinous groove. I will grasp Melanie's hand just like so, and I'm going to ask her to basically supinate her arm and flex her muscle, and I'm going to resist that motion. Go ahead and make a muscle and flex. Okay. And then if there were pain along the distribution of her anterior shoulder, that would suggest potentially a bicipital tenosynovitis, injury to the long head of the biceps tendon, and or laxity to the transhumeral ligament. This is the Liftoff Test, and it looks at any injury to the subscapularis muscle and or its tendinous portion. And so what I would do is I would have Melanie, could you please put your hand on the small of your back like so. I would ask her to lift off her arm off of the small of her back and press against my palm. Okay, and release. So if there were any pain associated with this maneuver, it would suggest that there were a tear and or injury to the subscapularis muscle or its myotendinous portion. This next examination is called O'Brien's test, and it is a test for shoulder labral etiology. And so in this examination, I'll have Melanie bring her arm up, cross the midline with her thumb pointing down. I will resist her motion right here and ask her, does that cause any pain? Okay, and then I would now place her palm towards the ceiling and then resist motion again. Any pain there? No. So that would be a positive test for labral tear or injury because in the first part of the examination it was painful. In the second part, when the palm was up, it was less painful or not painful at all, suggesting that there is a labral tear. This next examination is a test for what's called thoracic outlet syndrome. And so in this examination, I will ask Melanie to go ahead and abduct or bring her shoulders out to the side with her hands held high. I will then ask her to open and close her fingers like such. She will continue to do that for about 30 seconds or so, or longer. And if there is any pain or paresthesias along the distribution of her upper extremities into the hands, that is suggestive of thoracic outlet syndrome. Some are 30 seconds, some extend out to a minute, and some even longer than that. This test, though, has really good sensitivity and specificity, and therefore just by virtue of the patient following the instructions for exam completion, they will notice the symptoms pretty substantially and pretty of short duration. If the plan doesn't seem to work and the pain complaint appears to be much more complicated, one can always send a referral to the pain clinic, and we'd be happy to assess the patient and provide them with pain relief.